Welcome to Flourish, the podcast. My name is Frank Bernard, and I'll be your host for this episode. Wherever you're listening from, we welcome you. Arthritis is a painful disease, and millions of Canadians suffer in silence from it. That's why we're here to talk about the quiet and often misunderstood challenges that are associated with it. We hope this will help you flourish with arthritis. Today we're speaking with Maureen Beauchamp, who is 37 years old and lives in Nova Scotia. She's a wife, the mother of 2 young girls, and works in finance. She was diagnosed with rheumatoid arthritis 3 years ago, which is causing her to wake up most nights with painfully inflamed hands and feet. She has sought medical cannabis as an alternative to opioids and struggled greatly to access the right products. She shares her story with us today. Welcome, Maureen.
Hi.
Our second guest was raised in Gimli, Manitoba, and is a proud member of the Pimicikamak First Nation in Cross Lake. Dr. Shelley Turner is a trailblazer in the medical cannabis community, specializing in cannabinoid therapies for addictions, sleep and mood disorders, and chronic pain. Committed to serving underserved population, she's a harm and pharma reductionist and is a leading clinical participant in McMaster University's database for cannabis consumption and study. Dr. Turner, welcome to Flourish, the podcast.
Thank you.
As we're now celebrating the 20th anniversary of the legalization of medical cannabis in Canada, it is still a type of medication that can be hard to obtain and that can prove costly. Maureen's story, which we'll discuss today, appears not to be an isolated case. Before we dive into your journey, Maureen, perhaps you could tell us a little bit about your diagnosis and symptoms leading up to the moment where you started considering medical cannabis as a treatment option.
I was diagnosed in July 2017. It had been about after 6 months of having inflammation, inability. My joints would be very slow to move in the morning. And then I had gotten to a point where I was in a lot of physical agony every day, took myself to our local walk-in emergency hospital and basically said to them, I need some help. Physically, there is something wrong. I had blood work and basically 5 days was in and saw a rheumatologist based on my blood levels and started methotrexate to treat the disease and was given for pain management was given naproxen and a couple other, I can't quite remember. I wasn't given opioids right away, but they said if this doesn't work or if the pain becomes too much, that would be an option. I am fortunate I have a great relationship with my MD, and I said to her, at that point I was 35, I had 2 young children, and I said, I have a long life ahead, and I don't know if starting treatment course of opioids at my age is the best thing for long-term pain management, my body, just any of it. I said, if there's any alternative, I would like to explore that. And so I'm fortunate she was supportive. She was honest. She's like, I don't have the knowledge, but let's refer you to one of the cannabis clinics here in Halifax and see what they can do for you. So that's kind of where I entered the world. We do have a pain management clinic. We've got a few here. The problem is the wait list because it treats all patients for pain. And we have a fairly aged population here in Nova Scotia. So I would be lower down the list in terms. So it could be 2-3 years before I was able to see someone at the pain clinic. So I went to a private cannabis clinic. And since legalization here in Nova Scotia, there's only one pain clinic in Halifax. So that's where I went.
And so I guess, for you, the reason why it made so much sense was as an alternative to opioids, right?
I had gone through, I've had broken bones in the past. I've delivered 2 children. So I've had post-op recovery of opioids. And even after a delivery, it's incredibly difficult. I found it was just something I couldn't imagine being able to control pain, but be able to manage my day At that point, I was working in a different industry. I had to drive motor vehicles every day, so I wouldn't be able to consume opioids and continue with my job. I've got 2 children. So, taking copious amounts of opioids to also be able to be a mom and be attentive didn't seem like it's just not something I wanted to do. So
Yeah. Yeah, no, that makes perfect sense. And so obviously you maybe had a bit of a, past experience with cannabis before consulting, but were there any myths and misconceptions you had in mind before, thinking about that as an alternative?
Not really. I'd had enough knowledge, understanding that CBD is an intoxicant. I'd be able to continue on, for the most, not having it inhibit most of my day. I guess my misconception, which I discovered, was my experience that it's not. I expected it to be much more medical driven. So the serious conversation we had about my methotrexate, my expectation was it would be more medically driven versus what I experienced. It just wasn't what I'd expected. Like you'd said, 20 years in the medical, this has been legal. I just expected a certain elevation in terms of the medical approach to my disease versus
What actually played out?
honestly just trying to sell cannabis, and it was kind of my
Right. So
experience.
perhaps that's what we're curious about here is how. So once you get sort of the green light from your GP to say, okay, cannabis is perhaps something you can consider. So you went to a different sort of a private clinic. And what was your experience with that clinic? How did prescription process?
So I was referred. I went to they're in the a professional medical building. So that was great. I went in, I brought my husband with me because I wanted the support, because to me, it takes me back to when I was first diagnosed, and then I would cry taking my methotrexate because what it represented. And that's kind of how I felt about the cannabis, that this wasn't for fun or partying. This was medicine because I have a disease that could cause damage to me. So I went, I had to have a urinalysis done. I had to pay cash to have that done. Then I met with a nurse who went over kind of what to expect on cannabis. It's not a cure-all. Just that I understood from a liability point of view, taking cannabis and what it would do. And then I was moved on to what they refer to as an educator to help me kind of find the best product for me. He was very lovely. He wasn't knowledgeable in my disease, but was definitely knowledgeable in the product, which is helpful. I have an oral allergy syndrome, so I couldn't have cold pressed oil. So we kind of found something alternative that I could use. And then he basically left the room, went and got a piece of paper signed, came back and said, I've got your prescription. We're going to send it off to the supplier. They'll reach out to you. And that was it. And I was kind of finished with the clinic. And then I think it was probably about a week, maybe later, I got an email from one of the large providers and said, we've received your paperwork. You can pick from these products. We'll send it to you. That was kind of it.
Dr. Turner, does Maureen's story sound familiar?
I think in the day, it sounds familiar. So you talk back 2017
this would have been
or 20...
probably late 2019, early 2020. Yeah, so about a year ago.
20. Oh, okay. Yeah, okay. So not so far down the path. So you kind of bring up very interesting points in regards to cannabis clinics versus getting your prescription from your physician. And so unfortunately, how the industry is set up because of how it's positioned and the worry about safety, there's tons of restrictions. And frankly, from a physician's perspective, there's what we say is not a lot of evidence. So this is what I get busted about a lot of times. People say, well, how can you do that? And why are you prescribing that? And so the evidence that we have is really for neuropathic pain, HIV, cancer, palliative care, those types of things. So you have this risk-averse community of prescribers, which are physicians, and perhaps looking through a lens of stigma and prohibition. because this has traditionally been a drug of abuse and stuff that we would screen for, and so that's really the issue. So you have these cannabis standalone clinics that in the day used to be tied to a license holder or licensed producer that sells your cannabis to you, and they have relationships. Most cannabis clinics or cannabis-oriented clinics have relationships with the licensed producers, whether it's for educational agreements, etc. It's what they do with it. So your educational agreements goes to your people that are working to help you provide that education to your patients. And so in contrast, so in my day, starting off quite a long time ago, that was kind of the prescription mill routine. But what I realized very quickly, so case in point, we need to understand the science behind it and have a better understanding of the patient. And so for our practice, it's entirely different. We look at the patient, we look at your medication list, we do all kinds of screening, and then we guide you through the process in terms of dosing. And that quite often is what's lacking on many levels, just in terms of even being able to say, this is the standard, rubber stamped seal of approval by all colleges across Canada, because we know that cannabis does this for sure. Absolute randomized control trial, repeat. We're nowhere near that. And that's a challenge because of the plant itself and because of our really blossoming knowledge about endocannabinoid system, because boy, that's science. And that's taking me to a place in biochemistry that I don't want to go back to, but you have to, right? And so it is about the sophistication of cannabis through pharma, which is where we need it to go. We need patients like yourself, Maureen, to be able to go to a pharmacy.
And that's exactly like I was jotting notes and I said, why can't I pick it up with my methotrexate? I said, I'd be able to pick up my Tylenol 3s. I'd be able to pick up any more, serious opioids. They'd have no problem sending me home from my local pharmacy with that.
And so the other component of that, so how much do you pay for your methotrexate? So if you have insurance, is it covered? Yeah. And what about your cannabis? Are you lucky
when
to have
I spoke to the private clinic, it was a certain income threshold that I was over. It was I found it cost prohibitive too. Part of it from that clinic was self-directed on how to start slow dosing or micro dosing. And yeah, it was it's expensive.
It is. But the interesting thing is that if your provider, your family doctor, who obviously you're getting very excellent care from, prescribed opiates to you, guess how much you pay for those?
Zero.
Right. Not a lot. Right. Zero. So, case in point, if I may, I have patients that I have deprescribed off of opioids, and then have to go back on because they can't afford the cannabis. And, so you're seeing functional improvement, patients like feeling so much better and feeling more in control and here's the other thing. So again, coming back to this firm, hard, take this 3 times a day and you're going to feel better, this exact dose for everybody, cookie cuttering kind of that, looking for pharmaceutical kind of thinking. Whereas cannabis is very, again, coming back to the diversity within our own genetics. Your endocannabinoid system is different than mine. So my medicine would be different than yours. That makes sense. And that thought process of I need to take, certain amounts of this type of drug to make me feel better, where the patient actually, it is that you have to kind of go on that self-exploration. But the goal, key, I think, is close follow-up. So generally I have patients, they come back to me after a month. If they're having some, not quite sure about dosing, or they can call in sooner. And I had a conversation with a lady today who I feel terrible for her. She's disappointed because I can't give her the exact amount for her. And so precision needs to come into that. And that's where we come into doing more research.
Picking up on this, so you did have, Maureen, you did have a bit of an experience with it. So you did have access to it, even though from this conversation, we hear that the process might have been sort of, it didn't feel quite as medical or professional. Yes,
Tenuous.
let's put it like that. But you did, after all, get some of the products. Like you said, I think you were using something different than the regular oils. Did you feel the benefits of using that product?
The guidance was given to me that you'll start to notice a difference slowly. I had taken it probably about a month, and had built up to probably what my dosage would probably be. They were honest with me. They said it'd probably be 6 to 8 weeks maybe until you start seeing some effect. I said, okay. And then I ran into, because I was only given access to one provider, supply issue became an issue. I couldn't get the product I wanted. I wanted a very high CBD, next to no THC in it, because the plan was to take it overnight into the morning, because the morning is when I really have the most difficulty in terms of movement. Midday, I'm fine. Once I'm up and moving and the blood gets flowing, the inflammation comes down. I don't have pain, but it's the morning to get going. And I tried twice. It wasn't in stock. And I only really had one SKU to pick from. And I only had one supplier to pick from. So that kind of limited what I could do. And even just for, like, I did a little digging last night on our retail site here in Nova Scotia. We can purchase directly from our liquor commission. And there was one option for high CBD, low THC. I lied. There was two options. One was out of stock, and the other one was about $40 to $50, I think, roughly, for a small vial of it. So supply became an issue, and then I got no support back from the clinic saying, what do I do? And it was radio silence. And then I kind of just gave up, because I think, like Dr. Turner said, it's the support that I found was really missing. I'm fine with understanding, yes, this is a plant. We don't have as much clinical, very traditional science to it, but I didn't even have someone, pointing me, no, the ship's going in the right direction, stay on course, you're doing what needs to go, well, keep going. Like, not having any support from my supposed provider really took the wind out of my sails, and I gave up.
Let's stop here for a short break, and we'll be right back. Is medical cannabis right for me? How do I access medical cannabis? Will I get high? How do I use it? How can it help me? Get the facts about medical cannabis as an arthritis treatment option before talking to your doctor. Visit arthritis.ca/medical cannabis. And we are back with Dr. Turner and Maureen Beauchamp talking about medical cannabis and the hurdles to accessibilities and the sometimes undesired process of getting a prescription that can be troublesome, that can be tricky. I would imagine living in a remote area can be a contributing factor to that. So, Dr. Turner, how do you make sure you're in the right hands? How do you make sure the people you are consulting are the right people pointing you to the right direction?
That's a great question. So I think I kind of need to step back a little bit and just have an understanding of the system in itself. So the Cannabis Act essentially is looking at adult use, which is your rec market. You can rock up to one of the dispensaries and buy your cannabis and go home and use it. And then there's the medical stream. And so coming back to that recreational piece, as you can say, you can just walk up and buy. But with the medical piece, you have to access a physician or a healthcare provider like a nurse practitioner. And quite often, every province has their regulatory body that manages physicians. So the College of Physicians and Surgeons, where I practice in Ontario and in Manitoba, and they have their own rules as it relates to medical cannabis. So some provinces are very strict as to how medical cannabis is provided. From having your physician, your family provider having to write your prescription for cannabis, to a consultant, and then, of course, to medical cannabis clinics, which are generally standalone. They're not offering any other medical services. And so the difference, and I can, of course, I'm going to talk about my practice because I'm a physician and my main area of focus is actually in substance use. So I provide opiate replacement therapy, but I also provide medical cannabis. To come and see me at my clinic, you have to have an active provincial healthcare card. And then you book an appointment with me. And if I ever ask you for money, it's either for bus fare or coffee, but I'm not going to ask you to pay me for my services because it is covered by the province. So in all colleges, I believe, there is rules around accepting money for a prescription. And so that is illegal. We're not allowed to ask patients for, okay, you're coming in, you want a medical cannabis prescription, it's going to cost you $100. We're not allowed to do that. And so generally that's standalone. If you are a medical patient and you're looking for access to medical cannabis, if you have a family physician that's willing to write a prescription, they're few and far between because, again, you're self-selecting to that area of practice. Not everybody is seeking medical cannabis education, but I think it's because, again, coming back to the research and people needing guidelines.
Dr. Shelley, what
Mm-hmm.
isn't it? It seems almost double limiting because both rural, here in Nova Scotia, the doctor shortage. So having to go to your family physician what happens if you don't have a family physician? Like if you have to use a walk-in clinic as your primary caregiver for health, it seems so like you've got so many roadblocks to something that should be readily accessible and for 20 years
And
has
I would
been
even
eligible.
go further and say, even if you have access to a physician, your GP might not be comfortable to prescribe.
And I can give you an example. So I have many people that walk in and say, I've asked my physician for a prescription and they were marched out on their ear, don't come back.
But here's your opioid prescription.
Well, I mean, it's what people know, right? This is what we're used to prescribing. And there's a lot of pressure on that because to deprescribe, and what you're doing is you're seeing a safe supply of drugs that has been prescribed into the community. And that's a whole other story that I could get into, but I'm not going to do that for these purposes today. But people need access. So ideally in our utopia of cannabis world, Maureen, you as a patient, me as a physician, I would like you to come to see me as a patient and you could see me right across Canada. Wouldn't it be amazing if we had national licensing right across? Because then you could access me. You still can. So coming back to access, if your family physician wants to refer interprovincially and you have a physician that is on a provincial telemedicine platform that is provided, your physician could refer interprovincially.
That's really good to know.
It is good to know. And it's also an interesting thing to understand interprovincially, or your provincial college, what their take is on virtual medicine. Mm-hmm. So there's all of these college regulations that bind us, and nobody wants a letter from their college. Why are you doing this? So it's very challenging to practice in this space. And so you don't have a lot of providers wanting to do that because, frankly, it's rough. It is challenging because, you're always trying to tell people, yes, this is going to work. And people always say, what's the evidence? And you say, it's coming. And a lot of it is already here. It's just there isn't the discrete programs for people to have this training, even in university, in medical education. I think if you've gone into medical education 2015 or after, you're learning about the endocannabinoid system.
6 years. It's been 6 years. Like, that's wild.
I went to medical school starting in 2003. Not one thing about endocannabinoid system. So this is all self-taught and learning from people like Dr. McDougall and Dr. Mark Ware and all the neuroscientists, Dr. Matt Hill. All of these people are hugely important in building this body of evidence. And it starts with us. It starts with you, Maureen, as a patient. as well. So we learn from you.
Mm.
And I'm so appreciative of patients when they come and they say, oh my gosh, this is what's happened. And we monitor you and we watch you progress. And if you don't progress, we kind of try and figure out why.
Mm-hmm.
But it's learning from each other. So
there
both
definitely
students.
are some
For sure.
key learnings and things to navigate when you are being prescribed cannabis, such as your other medication. People who have arthritis have, sometimes a handful of medication they have to take. How do you make sure that there's no interference? How does the system make sure that these patients are taken care of?
Mm-hmm. So that's an excellent question, and we see that all the time. So in patients that are wheeled in by their grandchildren, they're in their 80s. My oldest patient is 98. So they come in and they've got a laundry list of medications, and so it could go either way. Grandkids want to help their grandparents, and they give them an edible. Well, maybe their grandparents are on a blood pressure pill, and sometimes we know that cannabis can actually drop your blood pressure, so that puts you at risk for falls. Some people take blood thinners. So if you've got funny arrhythmias, you take a medication like warfarin or any of the other newer medicines in that area. Do you guys know the game
Yes.
Plinko? Right. So the board, right? And you drop the chip in and it goes down these pathways. Think of your liver like Plinko. And so we have all these pathways that medicines go through and metabolize. And sometimes medicines will challenge other medicines, making the other one stronger, making the other one not work as well. And so cannabis goes through, 3 or 4 different pathways that we're aware of, along with other medications like the blood thinners. So things like that, it doesn't negate that patient or make them not able to have cannabis as a drug, but it means that you have to monitor them closely. So those are some of the things. What generally happens is that laundry list of medications, I take my blue pen and I write little dots beside those things, and I say, these are the things that I think we can deprescribe or really get rid of. And so that is the difference between going to a cannabis clinic, which I think is important maybe in some communities where there are physicians that are risk averse to writing those prescriptions. But I think as more evidence comes, I think you'll see more and more people incorporating this into their practice. And that's always my wish. I don't want to be the, one of 50 doctors out in Canada that are prescribing cannabis. I totally want to make sure that people are coming up behind me to care for these patients that are going to need the help.
In 2021, is there still a stigma or a perception regarding, social acceptance and so on, either from family, friends, work? Is that still a thing? Maureen, were you experiencing some of that?
Definitely. I worked when I was diagnosed and started this journey. I worked for an American company. Obviously, I worked here in Canada, but my colleagues in the US were randomly drug tested as part of their employment contract. Obviously, it's not legal in my province or my country, but it really had a trickle down attitude towards cannabis, and it had a heavy drinking culture. But as soon as cannabis was introduced recreationally, you wore a black mark. So even when I had decided to go down a medical road, which is perfectly legal, both medically and recreationally in my province, it was something I actually kept secret from my coworkers because I did not want career ramifications because I went down a certain road for my health. So fortunately now I have a different employer and I work with 3 women and it's all in Atlantic, Canada. So the attitude's definitely more improved and they're open to understanding why I'm going down this road. Whether they, support it personally or not, I've not had any backlash or any feelings at all that anything's in jeopardy because I've chosen to look after my health.
Yeah, I think, at the Arthritis Society, what the messaging is and should be clear is that, it's a medicine. It should be available. It's a medicine. People need it to feel better and to improve their health conditions. So it's hard to see sometimes that some employers don't feel the same way and treat this differently, even though it's been 20 years. It should be accessible, it should be affordable, and it should be accessible under the right healthcare practitioner supervision. Is there anything else we can do, Dr. Turner, to change that perception that it's still sort of an alleyway drug and not an actual medication?
Mm-hmm. And I'm so sorry that happened to you, Maureen, but you're not alone. And so changing stigma in post-prohibition, and I would argue we're kind of still in that. I mean, we're still mired in lots of policy that needs to change. But I think it really comes down to education and science. I think moving research funding forward. So our friends here at the Arthritis Society are very good at supporting research. And I bug them a little bit about, hey, why don't you come and work with us over here? But I think that and then providing that body of evidence to, talk about a pedagogical tool to educate physicians, right? How are we going to do this? And so I think it is really about the art and the science of medicine, and that's where this plant fits very nicely in, and we just have to be more creative in how we educate around this.
I find it interesting, and it just aside that with the previous company, and it's under my medical plan, acupuncture wasn't covered. Yes, we don't have direct science, there's not the case studies, but like 3,000 years of anecdotal evidence that acupuncture, it helped me wonders the first 6 months of my diagnosis. I find it's the same thing. It's the attitude towards it, because we don't have such traditional cut, dry, black and white scientific data about it. It's just written off. Like, it's just not supported at all. And I find that, how are we ever going to get to that support if we don't take the chance to follow down those roads?
So you talk about what we're doing is evidence informed. I have 8,500 patients. I have that much evidence in there that says I'm still here doing this work. I'm on my 6th set of dentures because I've had my teeth kicked out a bunch of times. But no, kidding. All kidding aside, it's challenging, right? It's challenging. So you're always kind of having to kind of fight for what you believe in. And it's really the patients that drive me, because they tell me. They're going to tell me if this is working, and they're going to come back and they're going to continue using it. Mm-hmm. And so our job as people that are providing that care is to collect as much evidence as that patient will give me. So I always start off when I see patients, I say, thank you so much for taking 30 minutes out of your day to do all those forms I've asked you to do. But it's important to hear your voice, and it's important to track what we're doing. So quantitative, qualitative data is hugely important. So I can trace patients back from their first initial cannabis prescription all the way through their journey. And it's fascinating to see it. Yeah, it's a great ride to be on.
For someone listening right now thinking, I don't necessarily want to go the opioid path, or maybe I want to add medical cannabis to the arsenal of tools that help me cope with arthritis and pain. What's the first step, and what should they be thinking about doing now?
So the science behind that, when we talk about cannabis's opiate sparing ability, we have receptors for THC in our brain. We have receptors for opioids in our brain. Cannabis comes in, lands on the THC receptor, but it also kind of slides over and tickles, I always say, the opiate receptor. And my science friends are all cringing and dropping on the floor. They can't believe what an intelligent answer I've given there. But that's what I explain to patients. So when you look at how our approaches to treating pain, it's the NSAIDs, it's the acetaminophen, it's, you're getting, weak opiates and you're moving up. Cannabis is third and fourth line. So what I've done is just flip that around, and I've put the cannabis first. And if patients want to try that, so we know that long-term use and of over-the-counter medicines such as NSAIDs, which are very near and dear to us that live with arthritis. However, I find that patients that take over-the-counter NSAIDs are generally over-medicating with that, and then we know what the consequences of that can be. So if we can start there, even deprescribing NSAIDs and other things, sometimes we don't even have to get to opiates. So I try cannabis first, microdose up, gradual increases. If patients come to me on opiates and they want to deprescribe, it's definitely a different protocol, and it's different for everybody. But for the most part, we're giving people the same type of cookie cutter start, but at a month follow-up, everybody's doing something different, and then we tweak there. We want to know how this is going to work in your body. So for opiate deprescribing, I would recommend this as first line for sure, particularly if you're thinking about opiates, not if you're on it fully, because then it's totally different protocol.
Maureen, thank you so much for taking the time. Dr. Turner, thank you so much for your great explanations as well. We are most happy to have you today and to speak about the challenges of getting medical cannabis and what to do if you are facing these challenges. Thank you so much. Thank you for listening to Flourish the podcast. Don't forget to subscribe to this series to get notifications when new episodes are available. If you have any questions or suggestions for future episodes, please reach out to us at info@arthritis.ca. The opinions expressed in this podcast are those of the guests. They do not reflect the opinions or views of the Arthritis Society.